We'll welcome Dr. Anagha Heroor from Mumbai, Anil Hospital, Mumbai. She is a member of Academic and Research Committee AOS and is a very good surgeon and a very nice speaker. So she'll talk on special situations in FLACS. Over to you, Dr. Anagha.
Very good morning to all of you. At the outset, thank you KSOS team for inviting me here and giving me an opportunity. So I'd be speaking on FLACS in certain difficult situations, no financial interest. So this was a patient who was operated for an IPCL in 2014 and then she came back to me with a nuclear cataract. She had a very high myopia to start with. We did a specular biomicroscopy which was normal. So these were some changes because we were contemplating doing a FLACS procedure, changing the pulse energy, as you can see here, from 4 to 4.5 microjoules. And then we go on to this is the Catalyst platform. The most important thing here is the OCT identifies the anterior surface of the IPCL as the anterior surface of the lens. So we have to manually change it, otherwise you would not get a capsulotomy. So this was the procedure done, the changes that were made. And once we go on to the operating table, we first stain the anterior capsule and then go ahead. Now, I was sitting temporally and now we first bring the IPCL into the anterior chamber and then above the iris and then make it vertical. I then go ahead and remove the capsulotomy flap. We need to be very careful in these situations because there is a slight reduced visibility and little bit of the cortex also has been disturbed, and I'm doing phacoemulsification underneath the phakic IOL. Now the reason is because this was the first generation IPCL and I thought it was a rigid one, so I would have to extend the incision before I go ahead, and that is why I didn't want to extend the incision. That is why we are doing it. But you can see also that there is an anterior capsular tear extension. So even if it's a LRCS platform, we need to be very careful about this. We are now removing the phakic IOL with a hand-on-hand technique. Be very careful to introduce viscoelastic before you remove the probe and keep the irrigation on, and then we are putting in the intraocular lens 90 degrees away from the anterior capsular tear. Post-operatively, patient did extremely well. Now this was another patient, a 49-year-old male patient, a one-eyed, who had both RK as well as LASIK done. So he first had a 18-cut RK done in 1989, and a few years later he was also operated in the same eye for LASIK. So you can see this was the lower one is the eye which is not seeing, it's the RD, old RD. And then this was the patient where you can see a lot of metallic deposits in the interface in the stroma. So here this was the ablation that you can see on topography, and this was the pentacam holiday IKEA report. You can see a lot of keratometric variability. So we gave him a guarded prognosis also. The most important part here is also the biometry, because it was not only post-RK, it was post-LASIK also. So if you see the Barrett-Ruque, for the post-RK and the post-LASIK, it was giving us totally different IOL powers. So here it was 21 with the Barrett-Ruque, whereas in the post-LASIK formula it was 23 and then 27 with the Higgs L. So we also used the ASCRS online calculator for both post-RK and post-LASIK, and you can see there was a difference. In the post-LASIK, it was giving almost around 23, 24, and the maximum was around 25. So to be on the safer side, we kept it a little myopic and used a 25 diopter lens. You can see the OCT was showing those metallic deposits in the interface. Again, we used a FLACS in this procedure, and we had to make certain changes in the settings also. The segmentation repetition was increased to 4, anterior pulse energy from 8.5 to 9, and then the vertical spot sizing from 35 to 30, so as to get a better cut. So here again the capsulotomy incision depth from 600 to 650, pulse energy from 4 to 4.5 microjoules, and then we went ahead with the procedure. So this is the Catalyst platform. You can see obviously we do it in another OR, and then you have the OCT image guiding system. There's not so much of difference in this patient, but we thought maybe because of those metallic deposits in the interface, it could hinder the capsulotomy. But fortunately, when you see now during the surgery, again we stained it first, and we did it with a scleral tunnel because there was an 18-cut RK, and we didn't want to do a limbal one for the fear of opening up of the incisions. And now we are removing the capsulotomy flap. Fortunately, it was a complete capsulotomy, as you can see here. And as Dr. Meenu also was saying, you can see that because of the air bubbles, you don't really have a red glow in the beginning, but once those air bubbles are removed, then the red glow increases. So with the 23 gauge microforceps, we are just peeling off the capsulotomy in a circular fashion. Remember not to pull it because it can cause an anterior capsular tear. Rest of the procedure is almost the same, the phacoemulsification and the intraocular lens implantation. Now because there were these RK marks, we need to be a little careful so as to not open up these incisions. And this was a patient with a very high myopia. You can see how the pupil is coming down each time we are removing the irrigation. Fortunately, the patient did extremely well, and we were happy to see that even post-op, he had an unaided of 6/9 vision. Now, this was a patient of trauma with subluxated cataract, and the advantage of a femtosecond laser is you can actually center it on the scanned capsule, and as we know, in such cases, the capsulotomy is the most critical part because we are also planning to put a CTR. So we are first anchoring it with the capsular hooks, and now we are putting in a CTR so as to give a good vertical and horizontal support to the capsular bag. Once that is done, then going ahead with the irrigation aspiration. Many times, if the cortical fibers are cut vertically, what we can do is you can go in with the polish mode, loosen up the cortex tangentially, and then aspirate it. That gives a more safer way of doing it. Then the capsular hooks are then removed, and then you can see that the IOL is well in place. This was a patient with an iris coloboma, where we are doing a FLACS procedure. Inferiorly, you can see that there is a coloboma, but fortunately, there was not much of phacodonesis at all. And during the surgery also, the lens was quite stable. So we are now removing the capsulotomy flap and going ahead with the phacoemulsification. And throughout the procedure, the bag also is quite stable. There was no sign of any zonular weakness apparent there. So once the phacoemulsification was done, the decision had to be taken whether or not to put in a CTR. But because the capsular bag was quite stable, we decided against it, and then completing the irrigation aspiration. The part of the cortex in the colomamatous area was dealt with at the last, and then we put in intraocular lens. This was the white cataract patient. It has already been shown earlier by both the speakers. So basically, sometimes you can expect that there could be tags, and we need to be careful here so as to not cause an anterior capsular tear. Rest of the procedures remain the same. The nuclear disassembly is not really that beneficial in such kind of cataracts, but definitely it makes things easier with a very good capsulotomy in the first place, because there are these intumescent cataracts which are very high propensity for an Argentinian flag sign, which can itself jeopardize the visual outcomes. So going ahead with the next, this was again a patient with RK marks, but since we have already seen earlier, I would not go ahead and complete this. Only thing is, it is not actually hindering so much the penetration of the laser. So it was found that the capsulotomy was complete even in these patients. This was a patient with a very hard brown cataract, a very demanding patient. He was actually a police inspector. And otherwise, without an LRCS platform, people would actually go ahead with asking for an SICS or increasing or giving even a block. But this was done under topical with the femtosecond laser. So it makes things easier. This is a place where we are also using the softening procedure. So you have cubes, and it's very easy to just separate out the pies from each other, and then it becomes more easy so as to reduce. It also reduces the phaco energy that is used in these patients compared to doing a phacoemulsification. So once these are patients who are very demanding, and this patient also was posted for a multifocal intraocular lens. So it is very, very important to have a perfectly centered capsulotomy and a good visual outcome, because in such brown hard cataracts, you can also expect some kind of corneal decompensation if there is a large amount of phaco energy used. So to conclude today, cataract surgery is more often a refractive surgery rather than just removal of cataracts. And my indications for femto is basically in those patients where you want a reduced phaco time, like a hard brown cataract, or patients who already have a compromised cornea, like a corneal guttata, where you need better centration, like you have a multifocal IOL, premium toric IOLs, multifocal toric IOLs, where you have a subluxated cataracts, and definitely in posterior polar cataracts. So with these platforms, we can actually go ahead and give better precision and better visual outcomes to our patients. Thank you so much for your kind attention. Thank you.
Thank you, Dr. Anagha. I think next is talk by Dr. Sai. While he is setting up, one clarification on this. Have you seen this retained small cubes of nuclei when you do it on these kind of very hard cataracts?
Yes, sir. So I think what we need to do is do a good irrigation at the end and then be very sure that all those cubes have been removed. Sometimes they can actually go and hide underneath at the periphery. But then with time we, learn to clear them up. So it
The
doesn't
only thing is
really.
that we need to
And
remember
then,
that this may exist and they stick onto the iris underneath and also so washing is
yeah,
a
washing
very,
is
very
important.
important thing to do with this.
Yeah.
Thank you very much. We have not used catalyst. I have not used, but I was just, sir was also telling about the scanned capsule
Scan capsule.
margin. What is that? If there is no subluxation, if the iris is completely covering the equator, how do you get that scan?
So we have 4 modules where four options. You can either center it on the pupil or on the scan capsule, or you can do a custom this thing centration. But we usually keep it on the scan capsule so that it is centered well on the bag.
That I understood, but what is this, how do you go till the equator of the bag when the iris is over the swan? How does
No,
it
you
scan?
don't have to go to the extent. You just select that option, that's all. It automatically selects the place where you do it.
I was wondering how does it automatically scan the lens? The available pupillary area. What is
Yes, yes. There's also a tilt compensation. So if there's a tilt in the lens also, it will compensate for that.
Thank you, Dr. Anagha. It's a very fine